I think the SPUR technology is a very interesting technology. It's really harnessing several things. Number one, the SPUR. So this is a device which expands like a balloon, but it's metal. It's like a stent in a sense as well, and it has sharp needles that we call them spurs, but it's little needles that stick out and they enter into the vessel wall. Now that's going to allow us to deliver drug into the vessel wall versus just applying it on the outside of the vessel wall, on the inside of the vessel, but not deep into the vessel itself. But also these multiple little spears serve as focal force concentrators, allowing the vessel to be more effectively opened. So we've long known with intervention that the bigger channel we can make, the better. If we can lessen with drug uptake the chance of injury, limiting the outcomes, that gives a better result. And then finally, that there are certain things that a patient must do for himself, like not smoking, like taking anti-platelet drugs, and that can make a difference. And so I'm very bullish on the SPUR. I'm also bullish on some of the research looking now, showing that if we achieve better platelet inhibition, greater than 30% platelet inhibition, that we can lessen restenosis dramatically. There have been a couple of articles, the group with Anahita Dua have published some of this. I find this remarkable data, and I think that there's a lot that we can do here because, again, guidelines, which are kind of agreements between doctors, but aren't always based on pure science. When we speak of antiplatelets in those guidelines, they typically use the words aspirin and clopidogrel. Well, we also have other antiplatelets that really are often more effective. We know that 30% of people are Plavix non-responders, up to 30%. That's been reported, yet that's guideline. That's the one they speak of in terms of the ADP receptor blockers. There's a drug, prasugrel, that doesn't have the problem of being a non-responder. Ticagrelor, another antiplatelet, doesn't seem to have that. Rivaroxaban, which is an anticoagulant, it's a 10A inhibitor that blocks the conversion of prothrombin into thrombin by affecting thrombin levels. That's also a platelet inhibitor because thrombin is one of the strongest stimulators of platelet activity via the PAR1 receptor. So it's all of these things. It's the immediate result that we get. It is the drug we deliver that works. It's how patients take care of themselves. And then finally, how we take care of the patient after, how we follow them, how we make sure that that all those things medicinally that we can do are in place. And I think putting all of those issues together is how we're going to solve the problem of restenosis, because by and large, we have pretty much solved the problem of crossing. In the vast majority of good centers, we can cross most occlusions. In the vast majority of centers, we can open those occlusions. The next big problem we have is keeping them open long-term, making sure a patient is one and done. We're not there yet, but we're getting closer all the time.